Hi, Dr. Kent.
Hi, Daryl.
Hi, thanks for being here today. We have an eager audience, both transgender women, LGBT in general, and just curious people, all wondering what it's like for a woman who has prostate cancer to go through treatment. Before we begin, can you tell us what you do and where you do it?
Yes, so I'm a reconstructive urologist who does gender affirming surgery. Right now, I'm working at Beth Deaconess Medical Center in Boston, Massachusetts.
Okay, and you're also, are you on faculty at Harvard and teaching there?
Yes, I'm an instructor at the Harvard Medical School.
Okay, because it's always nice to say Harvard, so that's good to know. So today, let's talk about the journey that a transgender woman will have when she is told her PSA is elevated and maybe even had a suspicious digital rectal exam and finds her way to your office. So she walks through the door, and aside from saying hello, what's the next thing you say?
So I always start out by introducing myself, and hopefully in the opportunity, the patient will then reciprocate with their name and really just starting the conversation off. When it comes to approaching a patient, everyone's going to be at a different stage in their life, had a different transition. So the first part is really understanding that individual. That includes their medical history, their social history, and then, of course, exactly why they're there in my office that day.
And I would, and I'm just going to use blatant imagination, but I would imagine that a transgender woman, even though she's been told she might have prostate cancer or she should look into the possibility of that or prostatitis or BPH or something related to the prostate, she's sitting in your office thinking, I'm a woman, I should not be here. How does that part of the conversation, how might that go?
Yes, so that's actually a very good point, and I think a huge part when it comes to recognizing prostate cancer awareness. Anyone that has a prostate can have prostate cancer. And when it comes to gender affirmation surgery, it's actually most common to not remove the prostate. So even if you've had a vaginoplasty, it usually still means that you have a prostate and are at risk of having prostate cancer. So yes, in this situation, it can be a possibility and something that we would need to look into for her. Absolutely.
And do you find that many transgender women, even, post-bottom surgery or, who have gone through transitional surgery, and correct my terms, I mean, if I'm using the wrong terms, that they just are still not aware that they have a prostate?
Some patients, absolutely, I see them and they're just not aware. In my counseling, when I am talking about vaginoplasty, I always talk about the prostate. It is very, very important in the context of urinary control and continence. It's very important when it comes to sexual satisfaction. So there's many roles that the prostate serves, and it's important to be aware that it's still going to be there and be a part of their body.
Right. And there's conversation around transitional hormone therapies, estradiol and all that, that somehow it protects people against prostate cancer. Can you sort of pull the curtain off of that?
Yes. So first, I want to point out that prostate cancer, generally, when it does show up, we're talking middle age and beyond, so age 50 and beyond. What we do know is that prostate cancer responds to hormones, meaning it can be used as a form of treatment. For individuals who are transgender and have chosen to have androgen deprivation therapy, blocking those male testosterone hormone, essentially they're having the same treatment that we sometimes use for prostate cancer treatment as well. In studies that have looked at this, there's a thought that particularly people who have been on hormones for a long time, it can have some form of protective effect. After many years on these hormones, the prostate actually shrinks down, gets smaller, atrophies. But we do know that despite the fact that it can be protective, you can still get prostate cancer. And in those individuals, it actually may be a more aggressive cancer, the type that has become resistant to these hormones.
And that holds true for women who've had testicles removed, et cetera.
Absolutely. So the testicles are the main source of testosterone. And when they're removed, oftentimes if they've been on medication to block the hormones, they're able to come off that medication. But yes, very, very similar effects as well.
Okay. So now this woman is sitting in your office, and an older woman. What I mean, the obvious surgery and radiation as primary therapies, or hormone deprivation and other things in the advanced setting. Those things are sort of equal to what a man would be offered, or are they somewhat different in how they're given to the person?
So the reality is we're basing a lot of our treatment decisions off of the cis population because that's the best data we have, but I wouldn't say it's equal. So when we talk about surgery, I think one of the key things to understand is the anatomy and how continence, control of the urine, comes into play. So there really are two sphincters, two mechanisms to hold the urine in. There's the internal sphincter, which is above the prostate at the bladder neck, and the external sphincter, which is the muscle. And that one really is in continuity with the pelvic floor. The pelvic floor supports that sphincter, is another way to phrase it. So when the prostate is removed for cancer, prostatectomy, you're really removing one of those sphincters, the internal sphincter. So what that means is your body is depending on that one and only external sphincter. So most people after surgery have to do exercises, Kegel exercises, to strengthen that pelvic floor and try to regain their continence. Where this comes into play is if you're having vaginoplasty. The vaginal canal is created right behind, so below the urethra, prostate, bladder. So going through some of those muscles of the pelvic floor. So in essence, you're compromising some of those muscles. So for most people, after you have vaginoplasty, you're not going to have continence because you have two sphincters and it's not going to have any significant effect. But if you've now had the prostate removed and then are having a vaginoplasty, where the only thing you're depending on is that pelvic floor, and it's going to be compromised, your rates of incontinence are going to be significantly higher than someone who hasn't had that procedure. So it's going to be different. Your outcomes are going to be different. The surgery itself is going to be technically more challenging in most cases. I say most cases because there's a lot of variables. Everyone's anatomy is different. Generally speaking, again, getting back to the effects of hormones on the prostate, after many years, the prostate is going to atrophy, shrink down. Smaller prostates make the surgery more technically challenging, harder to identify the landmarks. If you've had vaginoplasty before the prostatectomy, there can be a lot of scar tissue between the vagina and the prostate that can make the surgery itself more complicated, higher complication rates, that sort of thing. And so all of that needs to be taken into account when thinking about surgery as an option. When it comes to radiation, there are a whole host of other things that come into play when we're talking about vaginoplasty or future plans for vaginoplasty. So not all radiation is the same. There's different ways to administer radiation. You can have it externally applied. You can have radioactive seeds placed in the prostate. You can have a combination of the two. What we do know, getting back to this idea of a smaller prostate, when you have a smaller prostate and you try to put in seeds, for example, what they have found, and this is from research, again, in the cis population, because that's the biggest population that we have to study this. In people who have smaller prostates, the field effect, so the effect of the radiation on the surrounding structures. So in this case, we're really talking about the vagina that's created during vaginoplasty, can have an effect, a greater effect. Usually what that translates to is scar tissue in the vagina, so the vagina closing and what we call vaginal stenosis. The other thing is we don't know if the radiation therapy is going to be as effective for these individuals, particularly because for those with higher risk prostate cancer, which in this population, they tend to show up with more aggressive, higher risk cancer. Generally in the cis population, it's paired with androgen deprivation therapy. But for these patients who are already on it, we don't know if just administering the extra radiation will have as good a long-term survival and cure rates.
So this is, I mean, and thank you for all that. That was really cool. Cool and sort of dark too. I mean, it sounds like, well, let's ask why it's dark. What is it? Is it about too late to get a screening, or is it access to care barriers, or something else, or something biogenetic that makes presentation at a higher stage more prevalent for transgender women?
I think it's just a combination of everything. So awareness as far as the primary care doctors recognizing, even if you've had gender affirming surgery, it still means you have a prostate. Sometimes when individuals seek care, they don't disclose all of their history. Maybe they are, concerned they'll be discriminated against. So they, not too uncommon for them to not even tell that provider, the fact that they've had that type of surgery, especially if they're not anticipating any intrusive exams or anything like that. So really just, knowledge all around in the primary care setting, patients advocating for themselves, making sure the provider knows that they have a prostate. And then when it comes to symptoms, prostate cancer, by and large, does not have symptoms. Usually when it does show up having symptoms, it's the more advanced stages. And when we look back at the research, and really these are case reports for the most part, the patients who presented were the ones who start having problems. And when you start having problems, you're already at that advanced stage. And one other thing that I think is very important is when it comes to screening is going to look very different for someone who's transgender, particularly if you've been on hormones, particularly if you've had any type of gender affirmation surgery, because that affects the way you're screened and also the cutoffs on the values, the PSA blood work that we use for screening. It's different.
So what would be an elevated PSA number or range for transgender women?
So that is actually a very tricky question to answer because we don't have a lot of good research to base it off of. Most providers who offer prostate cancer screening, based on what we have agreed 1 or less for being the cutoff. In the cis population, usually we say 4 or less. But again, we don't have a lot of great data to support why that 1 as the cutoff would be the ideal cutoff. But that's universally agreed. If you are going to do screening, 1 would be a pretty safe number. If it's above 1, meaning to trigger further workup and evaluation.
All right. And just so our audience isn't confused by the term cutoff, if a cis man goes and gets a PSA, 4 and up is the range where we start talking about go see a urologist. For a cisgender woman, for a transgender woman, it's 1 and up.
That's correct. Above 1, yes.
Okay. So with so many transgender women presenting with a more advanced stage, let's talk a bit about therapies aside from the hormones, androgen deprivation therapy. Immunotherapy, for example, Provenge and these other things. Are they appropriate or useful, or are we just using anecdotal kind of evidence to figure all that out?
Yes, so we really don't have great data. So in general, prostate cancer is less common in the transgender population. When we look at then the people who underwent treatment, the treatment modalities that have been used vary widely, everything from surgery to radiation. Within radiation, there's different types of radiation that's administered. And then in the more advanced stages, you can have chemotherapy, other forms of androgen deprivation, and immunotherapy. So really, once you get to that point, we're talking about single individuals that we're looking at for guidance. And so you can't make really much of any meaningful conclusion based on that at this time.
So where do transgender women in the United States or even the UK or France or Brazil, where are they seeking treatment?
I would suspect it's probably with their local urologist. I don't know of any specific center that specializes just in care for this particular population. Where I work, I know we've treated some individuals. Where I trained in New York, there were some individuals there that we treated. I would say that if you are getting care, it's always important to have a multidisciplinary approach. I'm very fortunate that I work at an academic center. We have a really, really great, robust prostate cancer center. And when our patients go into that center, they meet with, the surgeon, the radiation oncologist. They get multiple opinions, because when it comes to prostate cancer treatment, no matter who you are, it's very individualized. What is best for you may not be best for the person next to you. And it really should be individualized based on your needs.
Yeah, and we're here in 2022, moving into 2023, faster than any of us can imagine. The idea of having virtual consults is now available, and that's gold for this population or really for anyone. And I think Malecare as an organization is advocating more and more virtual consults beyond your local facilities and physicians. Not so much because local is bad, but people just, there are people who specialize in things and they may not be in your neighborhood, you know. Well, you are in your neighborhood and that neighborhood may be in the middle of nowhere, or it's somewhere for you, but it's not near, you know, Deaconess or any of the large cancer centers. The Well, let's talk a bit about the actual moment-to-moment experience for a transgender woman seeking treatment. I mean, she'll be sitting in a waiting room with a bunch of guys.
No, no, no.
Go ahead. I
So
mean,
actually close to
mm,
50% of the patients who come to see a urologist are females. Within my practice, it is hugely mixed. I treat everyone. So a lot of urology practices, I'm a surgeon who does gender affirmation surgery. So naturally my practice is going to look a little bit different. But for the average urologist, you're treating men and women. So it's not the same as, for example, if you're going into a gynecologist office where you're expecting most of those patients to be female. The opposite is not true, fortunately, for urology practice. We treat a lot of females for many, many other conditions, kidney stones, incontinence, what have you.
yeah. And another thing that would be considered that the prostate cancer floor in a hospital will be a bunch of guys. Is that go ahead?
So most hospitals don't have a designated floor just for prostate cancer treatment. Usually it's mixed in with the other surgical patients or medical patients. So they would not be singled out in any way. Absolutely not.
Right. And another thing that the treatment locations, particularly around radiation, like the hallway outside of the vault or wherever they're receiving radiation therapy, will only have a cisgender male designated bathroom. That's not true either. Is that correct?
So this varies widely depending on which facility you're going to. Some facilities have gendered bathrooms, others have gender neutral, others have no labeling. What I would say is I think there's a big movement, especially in larger centers, academic centers, to have bathrooms that aren't gendered. I know where I work, there's no signage or gendering on our restrooms. That's not to say if you're in some rural, part of the country that there won't be gendering on the restrooms. But what I would say is that where they administer radiation, it is administered for many, many different reasons, not just prostate cancer. So I would be shocked if any single location had only a male bathroom, just because they're going to be treating female patients there too for other types of cancer or issues. So I wouldn't necessarily think that would be the case anywhere.
Good. The idea that some doctors may, and I've heard this over the years, not in the last 4 or 5 years perhaps, but some time ago, a doctor asked a transgender or said to a trans, I've got an appointment for you. It's at, I forget what the time was, but let's say 6 o'clock. And it was presented as like convenient, so you could attend to work, and that woman had a child, so you could, pick them up from school, whatever. But really the idea was the waiting room would be empty. And it wasn't clear and to me, it certainly wasn't clear whether the physician didn't want the transgender woman in the waiting room or was somehow being innocently protective of her. What are the concerns of, I mean, do you think that's a good strategy, or, to have special times for transgender women to present?
So in my practice, that'd be virtually impossible just because the amount of
Yeah,
individuals I see. But I'm very fortunate because that's the work I do. So I have a very supportive staff and all of that. Um, I personally hate that idea.
yeah,
I don't think there should be separate times. I think in many ways that works against what many, many people are advocating and trying for and want for themselves. Generally speaking, when you go to a doctor's office, the best time is in the morning because those tends to be the shortest wait times. And I'd want the best for all my patients. And yeah, no, I wouldn't recommend that.
yeah. I mean, these are almost common sense things, but I think these things are offered, out of innocence and slash ignorance, but really returning to innocence. Somebody means well, but hasn't figured out how to navigate anything, and I'm sure 20 years ago, people could have found something about my practice as well. So, I feel more forgiving about things from the past, but it's still for the patient presenting today. I mean, you're anxious and you want the best care, and you don't want to have to deal with any sort of perception of barriers or perception of discrimination or bigotry or anything like that. There's a practice in New York City, and I guess we shouldn't mention, but I think you're familiar with it from your time here, where they have something called a man cave in the waiting room. And it's sort of like sort of like it's this 1950s style living room with a big screen TV, and they have sports memorabilia and everything. I mean, it's basically where every one of my bullies grew up, and it's so triggering and quite awful. We have to get past that, as well-meaning as maybe that physician and their practice was. But what,
Yes, it's
yeah,
yeah, life can be very strange with such a dichotomy because I'm not going to mention too much details. I do know exactly what you're talking about.
yeah,
The irony of the situation is that the chairman there actually has a personal interest
yeah,
in prostate cancer in trans women, and he's doing a lot of research to try to get better data and to get answers. And there's a lot of complexity when it comes into building a space in a hospital and the donors who have built that space and what goes into centers and so many things that in many ways go into things. So it's often a complex situation. I'll just put it that way.
yeah. Still, we have to hold the hands of patients when they're confronted with that and help them
Yes. challenging.
So as we close this out, let me, and thank you so far. I mean, well, really informative, absolutely, but also like just gently affirming of what our listeners are going through, or even imagining they might have to go through. And I think one way to relieve anxiety is to just let people know in advance what's down the road, and they could sort of sleep a little better at night. What do you, I mean, what should be, or what might be the top 3 to 5 questions that every transgender woman should ask a urologist on their first or second meeting?
So when we're talking specifically in regard to prostate
Yeah,
cancer,
yeah,
usually the main questions I get asked, if someone has not had surgery, then they would want to know, how would this affect my future options for surgery? That's the most common one I get. The other situation that I commonly get, if someone has already had surgery, then they'll be asking, how would my prostate cancer treatment affect me because of my surgery? Which again, getting back to those special considerations based on the surgery they've had. And not everyone has the same type of surgery. And then the other important thing, particularly when it comes to urology, so our specialty really is, dealing with the urinary tract and sexual function. So those are the questions that we can really talk in depth and meaningfully about. So particularly any concerns about continence or sexual function. Those are the questions that we're truly experts on and can speak to very well.
great. Dr. Kent, thank you so much for this conversation. I guess in closing, I'd like to know, both for doctors who might be interested, as well as patients and women in the audience who are concerned about prostate cancer, are you and your colleagues available for virtual visits?
Yes, we do.
Okay, so they would call up Beth Israel Deaconess and just say, hook me up with a Zoom call, or how would that play out?
Yes, more or less. It gets a little bit more technically challenging depending on the insurance. Some insurances have limited as far as out-of-state telehealth. But again, we would work with you as far as figuring out what would be the best option in that case.
Great. And I ask that for the details of that so that people listening know you're not alone in terms of healthcare providers who care about you. You may not be able to walk into somebody's office if they're 3,000 miles away, but just as you and I are talking virtually, we now have the opportunity to connect virtually with our physicians that are relevant to our health, and that's a critical part of living a longer and happier life. So thank you again, and welcome to Mailcare's faculty. We're glad to have you.
Thank you so much for having me.